Morning, everyone. Thanks for joining. Glad to have you here. I'm going to introduce our speaker today. Thanks a lot for your questions as well as we go. We'll try to get to those at the end of the talk. California is often described as a bellwether for mental health policy, which means that California is an early adopter of mental health policy innovations, and that California is the first to make all of the biggest mental health policy mistakes on the grandest scale. California passed the Landrum-Petras Short Act in 1967, creating the system of time-delimited involuntary holds, 5150s, 5250s, 5585s, and so forth, and the legal structures for LPS conservatorship that we work with today. The LPS Act aimed to end inappropriate institutionalization, safeguard patients' autonomy, and facilitate prompt evaluation and treatment in least restrictive environments. It's obvious that the LPS Act has not achieved its aims, and there's no shortage of opinions as to why. Some say the LPS Act defines grave disability too narrowly. Others say it defines it too broadly. Some blame that it funnels attention to crisis response instead of prevention and treatment. And of course, we all lament that the LPS Act relies on strategies that facilitate involuntary treatment, never our preferred way to work. But as we will hear today, there's a more straightforward reason that the LPS Act has not met its aims, a failure of implementation. The LPS Act may have worsened disparities, led to an overuse of coercive approaches, and abandoned thousands of individuals with severe mental illness to die on our sidewalks because it has never been responsibly implemented. It's California's absence and abdication in relation to mental health policy implementation that has led to so much injustice for our patients and their families. This is a version of the argument we'll hear about today in Abdicated Authority, Decision-Making in California's Conservatorship Continuum. It's a tremendous pleasure to introduce you to Alex Barnard. Dr. Barnard is an associate professor of sociology at New York University. He completed his PhD in sociology at the University of California, Berkeley in 2019. Dr. Barnard studies the systems that serve and don't serve our most disadvantaged and disregarded patients, as well as their families and communities. And he studies that system's impact on us as well, how the broken system renders mental health practitioners variously burned out, powerless, cruel, overly coercive, and cynical. Dr. Barnard has 2 books coming out, both of which will be important for mental health practitioners. Mental States, Ordering Psychiatric Disorder in France and the United States addresses the topic of his dissertation, mental health care delivery in a context of stronger versus weaker health and social safety net systems. His second forthcoming book, anticipated in early 2023, is titled Gravely Disabled, Coercion, Compassion, and Conservatorship in California, the topic of today's talk. In addition to these book projects, Alex works hard to communicate with a non-professional audience in op-eds addressing issues that matter to our patients, including boarding care closures and abuses and reforms in conservatorship law. We're very fortunate to have such a remarkably talented and insightful scholar focusing on the mental health community's challenges and opportunities. Thank you for warmly welcoming Alex today for this talk.
Well, thank you so much for that very kind introduction. Hopefully, folks can hear me and can see what you ought to be seeing in terms of my slides. So, I'm so grateful to have been invited to speak with you today and daunted to be in front of an audience that includes so many both academic and clinical experts in the things I'm talking about. I hope that nonetheless, you'll all learn something new. And, if you have any comments or corrections, I welcome them. So I've spent some of the last 4 years examining California's conservatorship system, using both qualitative interviews and observations, administrative data, historical archives to present a portrait of the evolution of involuntary mental health care in California. I'm going to argue today that the system is one of what I call abdicated authority. Conservatorship is both a serious deprivation of civil rights and a potentially powerful tool to achieve stabilization and recovery. But the system lacks accountability to ensure that the two are in balance. Before I jump in, I want to offer 2 disclaimers. First, what I'm presenting are general tendencies. One thing that's clear from my research is that there's huge statewide variation, and I haven't been able to speak with every stakeholder in every county. This is work in progress, and I welcome corrections and critiques. And second, I want to emphasize that while I'm going to be very critical of the conservatorship system, I have deep respect for the people working within it. I'm not focused on why professionals, advocates, and conservatees make bad decisions, but why there are too often too few good decisions to make. So this project is in many ways motivated by something of a paradox. Although it's a common refrain that it's almost impossible to force people into treatment, that was a statement recently made by the mayor of San Diego, it appears that over time, California has actually put more and more of its citizens on 72-hour involuntary psychiatric holds, colloquially known as 5150s. And over time, there's also been a long-term trend towards more 14-day hospitalizations known as 5250s. Yet at the same time, when we look at not at short-term holds or hospitalizations, but conservatorship, we see a long-term decline. So conservatorship is a legal tool that allows a third party, typically a county public guardian, to place somebody in a locked treatment facility and consent to medication on their behalf. That's usually based on a finding that someone is gravely disabled or unable to meet their basic need for food, clothing, or shelter as a result of mental illness. As you can see here, the number of people going on to 30-day temporary conservatorships and 1-year permanent conservatorships is going down. Note that there's a difference in scale between the two graphs I just showed you. What this tells you essentially is that less than 1% of people in such serious condition that they're deemed a danger to themselves or to others or gravely disabled and forcibly brought to a psychiatric hospital are still there 17 days later. Now, on its own, the second trend would be a good thing. Ideally, people are quickly stabilizing and returning to voluntary community-based services. However, the literature, media reporting, or a glance at California's streets suggests something else. People are being subjected to many, many short-term and often traumatic interventions without putting them onto any long-term trajectory towards stability or transformation. So for the last 4 years, I've been trying to explain this paradox, and this presentation is an attempt to challenge or at least expand upon two widely cited explanations for what I just showed you. One explanation is that the main barrier to getting people needed services are the criteria and procedural protections given by the 1967 Lanterman-Petraeus Short Act. LPS was hailed as a Bill of Rights or Magna Carta for the mentally ill in 1967. But as a 2012 report on LPS claimed, it is really only, quote, a Bill of Rights for those individuals who are well enough to respond to treatment in a voluntary mental health treatment system. LPS, according to Governor Newsom, has sentenced severely mentally ill people to death. Alternatively, the opposing argument is that the people currently refusing services would accept them if they were more abundant or higher quality. This perspective often implies that most problems in the system would be solved by increasing funding for outpatient services and supported housing. I've been looking at media coverage of LPS reaching back decades, and as you can see from these headlines, the debate has been the same for almost 60 years. On one hand, we blame the ACLU and civil libertarians. On the other, Ronald Reagan and the stingy legislature. The core of my argument today is to suggest kind of an additional perspective, which is that new legal criteria for involuntary care and the new funding for services will not alone address what I'm calling abdicated authority. Even as the legislature debates expanding forced treatment, state government has largely abdicated its responsibility for the implementation of existing law. As a result, while many people exercise power over clients of the mental health system, no one has authority over the conservatorship process. Authority in this conception is the capacity to get a diverse set of actors in a complex system to work together towards a commonly agreed goal. My research identifies two core drivers of abdicated authority. The first is delegation. As you'll see, over time, the state has shifted responsibility for the public mental health system towards private actors who are able to indirectly determine who gets conserved. The second is discretion. Decision-making is given to a large range of public and private actors with different interests and incentives. Legal criteria, particularly grave disability, are being defined in inconsistent and incompatible ways across institutions and between counties. I'm going to highlight some of the consequences that I tie to this abdicated authority. One is that people are subjected to frequent, ineffectual short-term coercion. Legal criteria serve as a justification for abandonment of vulnerable individuals and families for other reasons. And new resources do not ensure that the neediest individuals get served. As a quick roadmap, most of my talk is going to focus on what I found about contemporary decision-making in the conservatorship system. I'm happy to talk about the parts of my research that are focused more on history and policy, which created the system of abdicated authority in Q&A or afterwards. So you'll hear me harp on this multiple times, but there's very little available data on conservatorship. We do not have a comprehensive statewide picture of who is on conservatorship, where they are, or how they got there. My approach is more exploratory. As you can see, I've interviewed 254 different stakeholders across 33 counties. I contacted the public guardian and LPS public defender in most counties, although their rate of response was very low. I also interviewed psychiatrists, parents, advocates, judges, outpatient clinicians, and people subjected to conservatorship themselves. I'm also going to be drawing on a variety of other sources, including the published academic literature on LPS and over 1,000 newspaper articles on LPS and conservatorship from 1967 to the present, available administrative data, observations with a full service partnership team that treats clients who have been on or headed toward conservatorship, and participation in working groups around conservatorship and long-term care. And what I'm going to try and do is present some broad descriptive patterns, usually based on administrative data, and use my interview data to try and explain what I think is happening. I'll talk briefly about the limitations of this methodology in the conclusion. In terms of just a quick roadmap for the empirical part of the talk, I'm going to start by talking about 5150 evaluations in the community. We'll then go to an ER, which makes a decision about whether somebody will be admitted onto an inpatient hospital. I'll talk about sort of the logic of decision-making in inpatient wards about deciding to apply for conservatorship. I'll then talk about how public guardians investigate those conservatorship referrals, go through what happens in the court system when those petitions that are filed by public guardians are evaluated by the court. And finally, sort of the end of what I'm calling the conservatorship continuum, which is the point at which somebody is placed in a step-down facility outside of a hospital. Okay. So we'll start with 5150s. In 2021, I went out with an outreach team assigned to the 25 highest utilizers of emergency services in one California beachside town. In one day, we visited 3 clients who the team universally felt needed to be placed on a conservatorship. But first, these individuals needed to be brought to a hospital on a 72-hour 5150 hold. Our first stop was to see Jerry, who was dying in the streets. He was a chronic alcoholic and weighed only 80 pounds and was now confined to a wheelchair. He was being kicked out by his homeless shelter. This had happened before, and he'd been revived by paramedics several times in the previous months while passed out on the streets. However, the team was worried that ER doctors would say his problem was alcoholism or dementia, not mental illness, and quickly release him. We then went to see Jolie, who was in crisis in public. She lived in an encampment that was facing an imminent sweep. When we spoke, she calmly told me about going to the moon with Neil Armstrong before starting to shout racial epithets at an invisible occupant of the encampment. Our team asked her if she wanted housing, and she said she didn't need it because she owned 2/3 of the property in the area. Jolie has been 5150 before, though, and each time it has required the police to go hands-on. The team is thus worried about potential violence against a Black woman. Finally, we visited Guadalupe, who is decompensating at home. She believed that she was being sexually assaulted by aliens, and when she opened the door, she had a long gash on her face that the team believes is self-inflicted. She's mute, but writes on a piece of paper she's not interested in restarting her medication. They're reluctant to 5150 her because in their eyes, she's been institutionalized, meaning that she knows what to say to the judge to get out. She also has an apartment, even if she frequently doesn't stay there, which makes it easy for the hospital to discharge her. So who got 5150? Not Guadalupe. It can be very difficult to get a 5150 for someone who is invisibly deteriorating in a way that is not generating a lot of complaints. One woman recounted calling the police repeatedly for her psychotic son. He thought I was a prison guard trying to poison him, so he stopped eating. I called the police several times, but their evaluation is just a flash. He was locking himself in the garage and he had the door chained so you couldn't open it. And if he wouldn't come out and they couldn't open the door, they'd just say, he's not right, but we're sorry, there's nothing we can do. She explained on the 6th time, I showed a police officer a picture from my son's driver's license, and then looking at him, skin and bones, the officer said, I'm going to call him gravely disabled. But it took that much. We're talking he lost 100 pounds before it was addressed. Police are also reluctant to 5150 people who, like Jerry, are dying on the streets. They are convinced, probably accurately, that facilities that can serve people with long-term trimorbid medical substance and mental health needs are basically inexistent. One police officer told me, we could scoop up people with minimal effort that very much meet that criteria. My kids could say, wow, that person should have some help. A lot of these are obvious, but where do they go? How do we ensure they're not back here in 3 days? How do we get people to help that's of any longevity? We don't have an infrastructure to support and serve that community. Instead, it was Jolie who was 5150. Her case is emblematic of what Chris Herring calls the rise of complaint-oriented policing. You can see on the left a graph showing the increasing number of calls about homeless people's behavior faced by SFPD. What he and other ethnographers like Josh Symes show is that 5150s are being used to temporarily remove people from situations where they are generating complaints, often in cases where police know the person won't be admitted to a hospital afterwards. A county mental health director explained the solution that has emerged. Police see people who are high, and a 5150 is an easy way to get them off the street. The ER won't admit them, and they come back. The system is kind of functionally dysfunctioning. What I'm illustrating here are three aspects of what I'm calling absent authority. So first, mobile crisis teams and police are often making decisions based on quick and superficial evaluations of people's momentary state, which is disconnected from any consideration of their overall trajectory across systems of care. Second, public authorities often require repeated and persistent private initiative to intervene. Some families even reported that police themselves had advised them to make their children homeless so they would be able to take them in. And third, 5150 criteria state when somebody can be held, but there's very little guidance to the police as to when they should. Police officers thus use the statute in line with their specific needs and imperatives. And while I just quoted a director who talked about the use of repeated 5150s as functionally dysfunctioning, there are clearly ways in which this is purely dysfunctional. Importantly, there are enormous racial disparities in exposure to multiple 5150 holds. In San Francisco, as you can see, 5% of the population is Black, but in 2020, 50% of people with 8 or more 5150s in the city were Black. Only a tiny fraction of those individuals connected to services. So once somebody's placed on a 5150, they're brought to an ER for an evaluation. Although there is no statewide data, the California Hospital Association estimates that about 1/4 of people brought in on a 5150 are ultimately admitted. This might indicate that some people on 5150s are placed inappropriately on a hold, or that some individuals need only short-term stabilization that can be provided within 24 hours. However, an overarching explanation for this low admissions rate is there are simply fewer and fewer places for ERs to admit people to. California has lost 40% of its acute inpatient capacity since 1995, and some hospitals no longer take LPS patients. While the number of state hospital beds has increased slightly, the state has decreased its responsibility for civil patients in favor of forensic ones, which now take 90% of state hospital beds. But even within this context, the exercise of discretion by ER clinicians also reduces the likelihood of admission for some specific individuals who others in the continuum would like to see conserved. Interestingly, historical data, as you can see on the left, shows that after new laws like LPS went into effect, grave disability became the catch-all category for sweeping up people who were deemed as ill but not dangerous. Today, however, with the limited personnel and resources of overcrowded emergency departments, attention and concern go towards people who are dangerous and disruptive over those who are disabled and deteriorating. One full-service partnership psychiatrist reported, if I'm filling out a 5150, I have to check a box, and I'll almost always do danger to self or danger to others. Those are more likely to get them in than grave disability. Grave disability, ER doctors are not impressed by that. Second, ER clinicians are skeptical of people they perceive as addicts, those who are frequent flyers who are using the ER for a place to sleep and get a meal, or people suffering from incarceritis, a sudden onset condition where somebody under arrest declares they need to go to a hospital. Someone placed in these groups may be released even if they also have a serious mental illness. Finally, the clinicians I spoke to felt a sense of futility about potential conservatees because of a lack of subsequent long-term care options. One ER intern explained, you can't make sure every discharge you have is safe for you to make. We have patients where you know they need to be conserved, but even if I admit them for some bullshit reason, in 5 days they'll be discharged one way or another. After I've fought for those patients, I am beaten to the ground emotionally and mentally. By comparison, a trauma like a gunshot wound, it's so easy, it's quick, we know all the steps, the ER works like a well-oiled machine. Those are the cases where my time, effort, and energy go. Although ERs in general are a hyper-regulated space, in the LPS system of abdicated authority, the actual role ERs are expected to play is undefined, and as a result, individual discretion dominates. In order to conserve someone, a hospital not only has to admit someone, but agree to keep them beyond a 14-day 5250 hold into at least a 30-day temporary conservatorship. This requires resisting the enormous pressures to discharge. Interviewees described insurance companies that call after 24 hours of someone not being acutely suicidal, demanding release, or hospital management that throws pizza parties for those discharging the patients the fastest. The result has been a collapsing length of stay. In 1990, people stayed an average of 25 days in acute care hospitals. In 2010, the median stay in community hospitals was 6.5 days. Conservatorships pose a particular financial risk because somebody waiting for the courts or a placement may no longer meet medical necessity criteria for an inpatient stay, and their care thus may no longer be fully reimbursed. Financial pressures have a particularly strong impact on California's conservatorship continuum because of the ownership structure of California's psychiatric hospitals. As you can see from the chart, our mental health system is heavily reliant on private for-profit hospitals, nearly 50% of psychiatric beds versus 1/6 for regular medical beds. Yet, as you can see, this is data from LA, a small number of county and VA hospitals produce the majority of conservatorship applications. Some hospitals put a variety of barriers to conservatorship that seem unrelated to clinical need. So as one resident described it, before you even start the conservatorship process, you have to present the case to a conservatorship committee and they make the decision, with the knowledge that that person will sit in a bed for however many months and not allow the hospital to make money on that bed. So they just deny everything. People know it's not part of the solution. You have to discharge. Now, counties do actually have some levers to push conservatorship applications, such as threatening to revoke a hospital's authorization to take involuntary patients. However, given the scarcity of private beds willing to contract to take publicly insured clients, this hypothetical authority available to the state and counties is one that is rarely used. As a case study of the kind of barriers inpatient psychiatrists face towards pushing through conservatorships, I'll talk briefly about Operation Dignity, an attempt in San Diego to conserve some of the county's neediest individuals. Dr. Briggs, one of the physicians behind it, is a consult liaison psychiatrist who lamented the moral injury that comes from the way that, quote, time and time again, you have to click the discharge button because there's nowhere to send anybody. One such patient was Eduardo. He's 69 and homeless, diagnosed with meth use, alcohol use disorder, and schizophrenia. He had 500 ER visits in the last year, including after being hit by the car, and is between moderate and severe dementia with a MoCA score of 11. With a ragtag band called, including the city attorney and fire department, he launched what he calls Operation Dignity to flood the system with conservatorship referrals. He told me, we've called it Operation Dignity because what I want is for people not to be found daily in the streets covered in their own feces and urine with skin breakdown. Most of his referrals, however, were refused by the public guardian. They said that because Eduardo had dementia, he didn't qualify for an LPS conservatorship, but that because he had schizophrenia, he didn't qualify for a probate conservatorship, which is the mode of conservatorship usually used for people with dementia. The public guardian was likely rightly concerned about finding a placement. In trimorbid cases like Eduardo, everyone has the authority to say no, and no one has the authority to obligate a yes. In Eduardo's case, substance use programs refused him because he lacked the cognitive capacity to participate. Psychiatric units declared him too medically complex, and medical units said he had too many behavioral problems. Dr. Briggs's crusade was put to an end by the hospital, which transferred him to a unit not authorized to make LPS referrals. Now, once an application for a conservatorship is made, it's investigated by the county public guardian. The statutes give public guardians significant power over conservatees, and this has fueled media portrayals like that in a 1972 LA Times article, which described guardians as people with total power who decide when they'll see the sunshine again. And certainly a lot of the coverage of conservatorship around Britney Spears sort of paints the same picture of conservators. In reality, though, public guardians' offices work with irregular funding, often report feeling marginalized within departments of human services or health, and have an unclear set of responsibilities for conservatees. They actually have very little control over the conservatorship process. They can't solicit applications, force a residential treatment program to take their clients, or re-hospitalize them unless physicians at the hospitals agree. As one public guardian told me, they think it's a magic wand. Oh, let's get them conserved and then everything will be solved. But we only have two powers, placement and medication, and we have no placement budget. Of all the people I interviewed in the Continuum, public guardians were often the most wary of using conservatorship. As one told me, taking away someone's right to self-determination is a big step. It's the last thing you want to do as a conservator. This has made some of them resistant to increasing pressures from county boards of supervisors, family members, or the general public to conserve more people. Statements like these reflect, in my opinion, both genuine concern for civil liberties, but also an alignment of values with the reality of limited resources. Given this, how do public guardians make decisions? Public guardians described evaluations as increasingly centered on determining whether somebody was successfully or unsuccessfully homeless. As one described, we've had clients who are homeless by choice. You or I may not feel that's good for them, medical health wise or mental health wise, but it's their choice. And if they can articulate that, I go to the soup kitchen, I go to Goodwill, I have Social Security, and I use that income to buy those clothes, and I have a sleeping bag, that's what I want. Well, the doctor may not feel that's appropriate, but if they're able to articulate that, we may reject that referral. Their decision-making thus reproduces a logic of the American welfare state, in which the state steps in only once all other options, including leaving an individual to fend for themselves, have been exhausted. That said, as you can see here, most counties reported that they filed on a large proportion of applications that are made to them by hospitals. The simple reason here is that so many people have been screened out earlier by private actors on the continuum that the discretion once we reach the truly public agency of the public guardian is largely residual. However, again, there's substantial variation between counties. This almost certainly reflects differences in county resources, which determine their definitions of grave disability. I sincerely doubt that this enormous disparity between San Diego and Los Angeles, for example, reflects differing levels of need in the two counties. The lack of authority required to achieve a commonly agreed upon goal within this conservatorship system is visible in the instance of criminal justice diversion. So there's a variety of ways people can be diverted from the criminal justice system onto conservatorship. Courts and jails can directly refer people. State legislation passed in 2018 allows courts to send people if they've been unsuccessful in less restrictive diversion programs. And additionally, people found incompetent to stand trial can be referred to conservatorship if competency restoration fails. And the dramatic rise in such referrals is visible on the left. Rhetorically, everyone I spoke to endorsed getting people out of jail into treatment. In practice, though, public guardians were resistant. One explained, we're seeing a lot more forensic clients coming our way. Sometimes it feels like we're being dumped on. This person is in jail, they're mentally ill, they're ready to go, but it's not safe to go out on their own. Thanks, but that's not really what we're here for. One public guardian described a client who, in his words, had been banned from my own county hospital. He's been banned from the step downs, and he's been banned from everywhere. This individual did not have a real mental illness like schizophrenia, but a very serious personality disorder. On a previous hospitalization, this individual, quote, talked like crazy to a psychiatrist who sent him to a state hospital where he quickly pulled it together. We were stuck because the hospital says he doesn't need to be here, and the community placement says, well, we don't want him. While he was waiting, he assaulted someone, went to jail, and was referred back to the state hospital for restoration to competency. The public guardian concluded, I don't know if the state hospital gets to pick and choose, but they will if he comes their way. In cases like this, he said, he would push back on the jail, law enforcement, and district attorney by saying, there's nothing we can do for this person. We have no placements to offer him. No place will accept him, and try to get them to drop the conservatorship. He concluded, quote, he's a young guy, only 30 years old, but he will probably be taken care of by the judicial system, not the mental health system. As the example suggests, until there are public mental health facilities and the authority to mandate them to take certain clients, prisons and jails will remain the bed that can't say no. LPS put into place strict legal protections against conservatorship, including a right to a jury trial and a requirement that grave disability be shown beyond a reasonable doubt. But past research, shortly after implementation of strict commitment laws in the 70s, found that courts were largely deferent to psychiatrists. As one public defender put it on an account at the time, when we're arguing grave disability, anything goes. What I observed today, though, was that even if courts were generally willing to grant conservatorship applications, courtrooms were also places where medicine's cultural authority, as Paul Starr defines it, its ability to define patients' problems and have those definitions accepted as true, was lacking. This was limited by the requirement that psychiatrists testify only to current grave disability. It was also limited by the organization of inpatient units in which doctors spend very little time with individual patients. Finally, cultural authority is constrained by the California Supreme Court's ruling in People versus Sanchez that doctors can only testify to what they observed, limiting the amount of patient's history that can be considered. Consider the following case. Public defender says, you said he was talking to himself in his room. How could you know that if you weren't there? Staff observed it. Public defender again. And you said that he attempted to go AWOL from the facility. The psychiatrist replies, yes. Public defender, did he tell you that? No, it's in the records. Public defender. I'm going to object to this testimony, which is not based on the doctor's observations or what my client has told him. The judge at the end noted, I don't have much to go on here since I struck the testimony about him cheeking medication, his discharge plan, and behavior on the unit, so the application is denied. Counties also face the difficulty of showing the nexus between grave disability and mental illness in a context of mass homelessness. I watched one case, for example, for a woman who believed the homeless outreach team was poisoning her. She said she didn't want to go to a shelter, but she promised the public defender that she would stay near a bus stop if released and would accept some food from other passersby. At the end, the judge announced that the nexus testimony is that she may refuse shelter. Conservatorship is not used to conserve people just because they're homeless. I'm very concerned about the homeless, but I'm not convinced that her inability to be sheltered is based on a grave disability from a mental illness. That linkage might seem natural, but the testimony strikes me as a bit tentative. Once somebody has been conserved, the public guardian is responsible for placing them in the least restrictive setting. Most conservatees are ordered by the courts to go into locked IMDs, subacute step-down facilities, or unlocked boarding care homes. But public guardians do not actually control access to those placements. Instead, in a fragmented system, California's counties actually compete for contracts, giving them access to these scarce beds. So one public guardian described, we tried to get a contract with IMD. It had a real recovery model. They care about their clients. We got my boss, the head of the County Department of Health and Human Services, to take a tour. But we didn't get it because we don't pay as much as other counties. We lost 6 beds in the last year, and it was very clear that it was because a large county paid more. We are completely at the mercy of the operators. Many conservatees are placed out of their home counties. This is the case for half of conservatees in San Francisco and 100% in some smaller counties with no step-down facilities. Contracting, however, worsens this. One public defender observed that her county had a 100-bed IMD, but because her county had lost access to all of them, all of their conservatees needing that level of care had to leave the county. A second consequence is that providers have enormous discretion over who they serve. Yuri, a soon-to-be out-of-the-business board and care operator, told me that he gets 20 referrals faxed per day from, quote, every hospital, and that he has 1 to 2 openings per month. He says that he prefers not to take people with depression because they sleep the whole day. He won't take anyone with a serious suicide risk because he had a resident die by suicide and it was a living hell, even though, quote, there's no way to prevent suicide. He'll make an exception for people who are hospitalized as a danger to self for running in front of traffic because to him, that's a really weak attempt. He also says he won't take people on meth, which screens out a lot of people because in his view, the entire homeless population is on meth. The point here is that delegating responsibility for long-term care to private entities was a key factor of facilitating deinstitutionalization of state hospitals. But it now means that the entire conservatorship system is beholden to the particularistic preferences of individual operators weighing their own financial incentives. The market for long-term care in California is also highly concentrated. Counties and nonprofits have opted not to run subacute facilities, and 2/3 of California IMD beds are controlled by 2 companies, Crestwood and Telecare. So a person with a bad reputation with each could have a very difficult time being placed. Teresa's son has been in an LPS conservatorship for 20 years, but it hasn't kept him stable enough to prevent 40 5150s and repeated sojourns in IMDs. After one long stay, he was discharged to a community provider. They failed to give him his injection and he was hospitalized again. At this point, she explains, my son had bombed out of several Crestwood facilities and they said, nope, he can't come back because he acted out. So the acute hospital referred him to a state hospital. There he stabilized and they convinced the one remaining Crestwood facility with which the county contracted to come take a look. His case manager thought he was ready to go. His conservator thought he was ready to go, but the representative of the company declared, no, we think you need a little bit more time. For Teresa, it's the prime example of what she saw as the risks of having private companies like Crestwood and Telecare monopolizing this whole thing. The private organizations get to decide who they'll take, and they'll say, nope, we're not taking your son. He doesn't look good on paper. Her son was so frustrated, she says, that he acted out, got arrested for violence against staff, and spent the next 4 years bouncing between solitary confinement and the forensic wing of that same hospital. The system seems incredibly unfavorable both to counties and inpatient clinicians. State officials recognize this. One told me, this is a question we're posing right now to counties. Why, if you're contracting with IMDs, doesn't the contract require that they take certain people? The answer, obviously, is that one county has very limited leverage in a context where there are 57 other bidders for scarce beds. But since the state pays for 0% of IMD care, it has little stake in regulating this unfair system. For reasons of time, I'm not going to talk about the part of my research that analyzes what happens to conservatees once they're conserved. That means, unfortunately, I'm also not going to share data from my interviews with conservatees. I'll just reiterate again, there's no statewide data on who is conserved, where, and what outcomes. I do have some limited data that I'm presenting here from San Francisco, which provides us some hints. So conservatees are mostly male, nearly 50% of them are over 60, and they appear to be skewed non-white. Although African Americans are less overrepresented among conservatees than they are among people with many 5150s. Whether you see this as a problematic disparity depends on whether you see conservatorship as a harm or a help. Most people are in locked facilities, but about 1/3 are in unlocked setting. I'd also like to sort of note that there's a basic lack of agreement about the goals of conservatorship. One public guardian told me, when we get a referral saying gravely disabled, we want the psychiatrist to confirm that the prognosis is not for any sort of recovery, no chance of participating in normal life activities. Other counties, on the other hand, adopt a recovery-oriented language focused on increasing choice and independence of conservatees. Finding a lack of consensus about goals is reflected in unclear standards around guardians' practices. There's enormous variability in how often guardians visit their wards, or if they, for example, they treat a conservatorship as automatically granting authorization to forced medication. So a quick overview of my empirical findings. At the first step, we can see that police are unlikely to 5150 someone for grave disability and often require repeated initiative from private actors like outpatient clinicians or family members to take action. ERs apply LPS criteria strictly and use grave disability less than dangerousness. They also frequently discharge people whose problems are seen as primarily coming from drug use, poverty, or criminal justice contact. Hospitals face intense financial disincentives against applying for conservatorship. My interviewees suggested that county hospitals were more likely to apply in spite of the financial implications than for-profit ones, some of which refused to take LPS conservatees. Public guardians investigations often focus on whether somebody is, quote, successfully homeless or able to meet their needs in some very basic way. Public guardians are resistant to taking responsibility for new populations like those referred from the criminal justice system. Courts rule based on whether the person at a given moment in time can articulate a plausible self-care plan or find a willing third party. The evidence that can be brought into court is sharply limited. And finally, California's system of mostly private placements is able to impose on counties a preference for people without drug use, violence history, or complex medical needs. A concentrated market allows for practices of cherry picking and blacklisting. What we see across these steps is abdicated authority, that no actor has information, resources, or coordinating capacity to mobilize everyone in the continuum in a common project towards shared aims. So we reached the end of this talk. I want to talk briefly about reform. As I mentioned in the introduction, people have been talking about reforming the LPS Act since it was passed. However, I think we're in a qualitatively different moment, both in the volume of attention to reform and the arguments being made for it. This is based on an analysis of 600 newspaper articles on LPS from 1967 to the present. And I coded these articles looking for what problems were attributed to people with mental illness that required involuntary treatment. In the first phase, media talked about patients falling through the cracks, failing to get treatment in the community, and posing a heavy burden on families. Around the turn of the century, media picked up on biomedical narratives about mental illness and leapt on the supposed efficacy of a second-generation antipsychotics. However, there was a flip side to this narrative. Attention to violence, incarceration, and homicides increased, painting a portrait of dangerous brain diseases. More recently, though, attention has shifted from the harms happening to people, to the harms happening to people with mental illness themselves. As you can see, this new narrative of people dying on the streets emphasizes homelessness, drug use, victimization, and a lack of medical care. In this framing, forced treatment has become a progressive form of compassion. One of the most prominent recent reform attempts is SB 1045, a bill pushed by legislators in San Francisco. It would create a new conservatorship pathway for people subject to 8 5150s and diagnosed with mental illness and substance use. It provoked huge amounts of conflict, with the Voluntary Services Coalition describing conservatorship as one step shy of the death penalty and distributing flyers depicting the public conservator as a dog catcher, as you can see. Yet as of March 2022, when I did a follow-up visit to SF, only 3 people had been conserved, even though the city thought 55 people would meet these criteria. What happened? I asked one person in the city involved in the program who told me some hospitals are choosing to participate and others are choosing not to. I'll call when one of our clients is hospitalized and say, "Are you thinking conservatorship?" And they'll say, "We don't do that here." Hospitals refused to give individuals the required sheet notifying them they were on the conservatorship pathway. In other cases, clinicians did not give the right diagnosis, noting that somebody was malingering rather than having a mental illness and substance use disorder. As a result, those 5150 holds didn't count towards the 8-hour hold limit. The lesson here is that San Francisco lacked the authority to make key institutions, hospitals and ERs, participate in the pilot, and they didn't. A takeaway here is that new criteria don't matter if you don't have a system of care prepared to implement them. So a few broad conclusions to wrap up. So first, I want to insist that California's mental health system does not necessarily have a lack of coercion, but a lack of authority over the use of that coercion. If we look internationally, California has high rates of initial holds and hospitalizations, but those episodes of coercion don't seem to be adding up to anything more than more coercion in many cases. Second key finding is that legal criteria like grave disability are ultimately being defined by resource limitations, not the law. As one public defender put it, in our county, we have 76 acute psychiatric beds. If all 76 are filled up, then grave disability means one thing. If they've got some beds that they can put some people in a subacute to free up some beds, then grave disability means something else. If we build a second acute care hospital tomorrow, we doubled our capacity for involuntary acute care, we would find that there's actually now 152 people who meet the criteria for grave disability. And if we shrunk it down to 30, we'd find that a lot of people, it turns out, are not gravely disabled. Who gets into those beds is heavily shaped by the delegation of the public mental health system to private entities. The inability to get those entities to care for the most complex individuals drives a sense of futility among clinicians throughout the continuum. Finally, I argue that while conservatorship is an important legal and clinical tool in the mental health system, it is not being approached as a potentially evidence-based practice. It's not an intervention for which we currently have a clear target population, best practices for its use, or outcome measures. We thus don't know, for example, whether it's useful for some of the populations currently being pushed onto conservatorship, like individuals with a criminal justice history or a substance use disorder. So what are some principles for addressing this abdicated authority? Currently, there's no dedicated state official responsible for the involuntary treatment system. The state should have dedicated leadership for LPS that's promoting best practices, setting objectives, and collecting data. Second, there need to be more research and pilot projects on who benefits from conservatorship, what elements of it are beneficial. For example, a pilot in San Francisco called Community Conservatorship focuses on medication compliance while allowing individuals to live in the community. And Dr. Bromley is very involved in, I think, a very exciting outpatient conservatorship pilot, which is attempted to conserve people from the street without necessarily passing through an inpatient hospitalization. Third, I've argued that the state needs to regulate a contracting system with private providers of long-term care that is complicated, unfair, and inefficient for counties, providers, and service users. I think there are limits to how much we can actually delegate care. There needs to be a public backstop with a mandate to take the most complex individuals. The state ought to create an entitlement guarantee so that people will only be conserved when they've been considered for a full suite of high-quality alternatives. Things like enriched residential services, sometimes being referred to as housing that heals, psychiatric advance directives, or enhanced full service partnerships. Finally, I think that rewriting LPS criteria is a high conflict reform with low payoff. More important is the conditions under which criteria are used. Finding ways to allow clinicians to more fully incorporate collateral and history seems crucial to avoiding a cycle of repeated ineffectual coercion. I'm not going to go through, I'm just going to quickly highlight some other research that's happening, including some recently published research on conservatorship that's very exciting, some work from some other sociologists working on these issues in California. And then if you're curious, I'm just listing two papers from myself tied to this work. So to close, I want to just mention some important limitations. One is a lack of a representative sample, particularly of people subject to conservatorship. It's been very difficult to recruit individuals who have been on conservatorship to speak with me or members of my research team. There's certainly potential biases that are introduced by a low response rate from certain kinds of agencies like public guardians. This is research that relies on self-reports rather than direct observational data, although I'll say there was a fair amount of consistency across these interviews. And limited unreliable quantitative data means that it's very difficult to describe trends and racial disparities, as much as we have lots of reasons to think that involuntary care is being used in ways with disparate impact. I want to close with a caveat that I think is important in a debate that is often sharply polarized. I think that our conservatorship system as it is has both false positives and false negatives. Reform needs to recognize that there are people who would benefit from the intensive support that's currently available only through conservatorship who are not receiving them, and also that there are others who are lingering on conservatorship or being placed on conservatorship because of our failure to identify and fund alternatives. Thank you very, very much for your time and attention. I'm again very grateful to be here and look forward to any questions or feedback that you have.
Thank you so much, Dr. Barnard. We're all giving our virtual applause. It's always unnerving not to have a chance to thank the speaker through our applause. I am really grateful for your storytelling about this complicated set of issues. Just to say, it always invokes a kind of intense familiarity hearing these stories. It's sort of at this point so familiar and obvious and known to those of us who work in this space, and then also still shocking and astounding that this is how things work. This is the system we work in, and so useful to have someone take a close look at how things work and tell the story before us. We've got some great questions in the Q&A. We've got a couple of hands up as well. Dr. Meldrum, Dr. Barron, I see 2 hands up here. If you are able and would be willing to do so, if you could put your question in the chat, I will try to triage and navigate. If that doesn't work for you, please keep your hand up and we will call on you for sure. We have, first of all, a data question, technical observation from Dr. Vlaskovits on the graph that does not include data from implementation of 5270s, additional 30 days for involuntary inpatient care. In a way, this is a terrific question about the graph presented at the very beginning because of the way that it underscores the data limitations here. Hard to get complete information on the array of different mechanisms. Dr. Castillo raises a question in the Q&A. You described hospitals' internal conservatorship committees, which review and often reject applications for conservatorship before they reach the public guardian's office. Our hospital has such a committee. What advice would you give to those committee members for the next time they review a conservatorship application?
Wow, those are very important questions. I think I'm going to do my best with one of them. I first want to speak to the data question. I often wonder about whether to include sort of any of these numbers in my talk at all, because it's based on the California involuntary detention reports, which are put together by the Department of Healthcare Services in the state. But they are sort of profoundly flawed, including having sort of cells that are nonsensical, right? Like the most recent one from the state says that 1 in 10 people in Alpine County was 5150 last year. Right, so that it's clearly like an error in a zero that has been imputed to them, and that includes the inclusion of 5270s. So it's an interesting question of if we believe this trend that there is some sort of long-term decline in the number of conservatorships, which again it's hard to be sure because of how incomplete the data reporting is. You're right that one possible explanation is that more people are going on to these 30-day 5270s, which are sort of obviating the need for conservatorships. So I think that's a really I think that's a really important point, and potentially very, as I'm finishing on my book, I'm sort of asking myself whether to include any of these numbers at all because it's so uncertain, and I'm very hopeful that the state is going to improve on that. In terms of the conservatorship committee issue, I mean, I think I am not trained as a clinician, and you don't want me deciding who should go on to conservatorship, but I do think what became the sort of suffering that I heard, a lot of clinicians who just spoke to me with so much, distress, like the clinicians involved in Operation Dignity, was this very strong sense of how, financial factors seem to be impinging on clinical decision-making. And I think even more than sort of the raw, there's sort of a caricature version of this, which is the hospital saying, oh, we're not going to get reimbursed, so, discharge this person to the street. It's also often this question of step-down placements, right? That hospitals seem to be reluctant to keep somebody on an acute inpatient ward for long periods of time when they shouldn't be there, just because they're waiting for a step down placement that isn't available. So I don't think I imagine one person working on one of these committees, it's very difficult to change that system. You can't sort of conjure up step down placements, right? But I think it is about at least from my sort of interviews with clinicians, it's about, making people feel like their clinical judgment is being protected from what often seems like purely financial or administrative concerns. And I think it's revealing that some of the people who worked in hospitals with these committees, their perception was that these committees exist just to deny everything, which I think is probably not what it feels like when you're working on those committees. But so that's, I think that's not that's not a totally satisfactory response, but I think that's probably what I have to say on that.
Thank you for that. Terrific set of questions in the chat from Dr. Agras. Please comment on the tension between self-determination versus the common presence of anasagnosia in mental illness. Simple question for you.
Yeah, that seems like the biggest one. I mean, I think, I'm somewhat convinced, there's this sort of, the claim that gets circulated among sort of advocates is often that 50% of people with schizophrenia have anastagnosia, and certainly, even in my, not nearly as extensive sort of my observations when I've been shadowing clinicians, I mean, there are moments where it feels like, okay, that lack of insight is right there in front of you. But I do think in some ways, like the concept of anastagnosia is doing a little bit too much work in terms of explaining what's going wrong with the system. That it's sometimes a little bit too easy to sort of talk about people's resistance to care through the lens of anastagnosia, rather than thinking about, for example, one of the things this research really highlights is the need for persistent engagement, right? That we often have this sort of, we have a voluntary system, which is like, you have to say yes to care or we won't do anything. And there's an involuntary system where your consent sort of doesn't matter. But I think a lot of the clinicians I've talked to who are thinking about alternatives to conservatorship are really emphasizing that idea of sort of relentless and persistent engagement. And it's only once you've really persistently attempted to engage somebody, focusing not just on their medical needs, but their social needs, their housing. The number of people I interview who say, I really loved that my clinical team, like I really connected with them when they took me to the dentist or they got me an ID, right? Like those kind of social needs. I think it's only after we've really engaged in that sort of very relentless, persistent outreach that kind of doesn't take no for an answer, but isn't, really forcing somebody into treatment. It's just not it's just pushing for that yes. I think it's really only at that moment that we really know, what extent, what proportion of people it's really anastagnosia. That's the explanation for them, declining care.
I want to bring to your attention this excellent question from Dr. Chung. Conservatorship and locked placement can be described as life-saving, and it's also a scarce resource, especially the placement, which arguably many or most conservatees need, and they're in short supply. Other areas of medicine face similar issues of resource rationing, like organ transplant, and there are systems in place to systematically manage that demand and supply problem. Is there an equivalent approach that would work more systematically?
I think that's, it's such an important question. So another part of my research was sort of my dissertation research, which isn't really, I didn't reference in this presentation. It's not really part of this book, but was in France, which has a kind of truly public mental health system. But like most truly public systems, they actually do a lot of rationing. There has to, a lot of thought has to go into sort of the centralized allocation of scarce resources. And so I don't know specifically, what kind of models exist around, sort of how to ration access to beds. But I think that's actually exactly where you need state authority, right? So long as, step down placements are limited, you do actually need, I think, a statewide system with some sort of clearly articulated criteria of who's going to have priority for access to those beds. I mean, currently, what really determines access is how much money your county is willing to, put forward. I mean, I've talked to many county mental health directors who are honest about the practice of, we'll go to the neighboring county and say, we'll pay you $50 more a day for your step down beds if you, basically give us access to them, and basically another county loses access to them. So I think you're correct to say we need something more similar to how we allocate, scarce, organs for transplant, where there is some sort of, agreed upon and, therefore kind of state regulated criteria. I think that's really important.
Yeah, Alex, I wondered if you could say a little more about the French example. There's an interesting question here in the Q&A. Have you looked into other systems like the French that focus on making work a requirement? So the core of the question here is about work and the role that that might play. And you may have comments on that, as well as some other aspects of the French system that make a difference. This requirement is linked to health coverage, no coverage unless you work, and starts right after high school, if not going to college. Work seems to solve a lot of problems. Do you want to say a little more about France versus the US?
Well, it's so interesting. I mean, I very much appreciate a France question, and then I'm sort of like surprised you landed on the work question, because one of the things that struck me when I was in France was actually how central work was to their approach to people living with kind of severe and chronic mental illness. That they have a very sort of robust set of programs that are designed toward the goal of getting people living with severe and persistent mental illness into work for kind of a lot of the reasons that you're talking about there. But they're more comfortable with the idea of kind of sheltered or protected employment, so which is something that has largely is kind of no longer seen as the best practice in the US and is sort of declining here. And I think that after having done all that work in France, I was very surprised to come back to the US, where we often think, okay, France, they have this generous welfare state, so no one is working. And in the US, we don't have a good welfare state, so everyone has to work. And it's actually very much the opposite, in the sense that France had this robust system of supports that actually allowed people to try and work. Whereas in the US, I hear very few conversations in this space around employment. I think the sort of baseline structure of the French system, how it is operationalized, there's a lot of questions right now, but I think the baseline structure of the system makes a lot more sense than ours, which is that it's population responsibility. So you have the countries divided into what are called sectors of about 70,000 people. Each sector has a public psychiatric team, which includes set of clinicians, some sort of outpatient programs, and beds in a hospital. And the point is that everyone living in that 70,000 person unit, it's clear who's responsible for them. It's this psychiatric team. And then I think also crucially, it's the same team that is following somebody on inpatient and outpatient. You could potentially have the same doctor in both contexts, or at least the same care team. So I think that kind of population level responsibility and an integration of outpatient and inpatient care, I think, is really important. I think post deinstitutionalization in the US, we sort of built a system a little bit imagining as if hospitals didn't exist, and yet hospitals remain very, very important to the system. They're just often really cut off from it. When I did observations with an FSP team as part of my dissertation in Northern California, the hospital was almost this kind of like magical black box. Like they felt we don't know when people are going to go in. We don't know when they're going to come back out. We don't know what state they're going to come back out in. And I think it's extraordinary how sort of separated those institutions are, given that in France, you'd really have psychiatrists who spend, the afternoon in the hospital and their morning in the clinic seeing the same patients, basically.
Terrific and really important observation, how disconnected and fragmented hospitals especially are from the rest of the care system. I just want to end with one last question. It's a great question for you, Alex. What advice have you for conservators of children, or for family members, parents generally? Thanks for this question. I think it'll be our last one for today. It's a terrific one.
Boy, that's such an incredible, what advice for parents? I've heard so many sort of heart-wrenching stories from parents about their struggles in terms of getting conservatorship. Yeah, I struggle to come up with kind of a sort of neat and quick response to that, because I haven't, I think that, families are often being asked to sort of step in as kind of the glue that links a bunch of disconnected parts of the care system together. And I think often the most important role that families can play is being sort of the information repository that actually is the sort of the people who actually carry with someone their history and what's worked for them and what hasn't worked for them and what's been tried and what hasn't been tried, as they move between often a bunch of providers that aren't able to share that information between them. But I think, and I would say, I think unfortunately, the most I can offer is kind of solidarity with just how challenging that position can be in, and of course, how challenging it is for people who can serve themselves too. Apologies to not have a better response to that very important question.
Very important answer. The way that families are required to be the glue to keep these systems interconnected, really an enormous burden to place on families. Thank you again, Dr. Barnard, for a terrific presentation. Very important set of issues, lots more to say about this. And I really encourage you all to keep an eye out and purchase Dr. Barnard's book, coming out hopefully early 2023 on conservatorship. Again, it will be familiar and also shocking and spur us to action, I hope. And grateful for your scholarship. Thank you for coming to talk with us today.
Thank you very much for the invitation. I really appreciate it.